Morning, everyone. Welcome to Cardiac Grand Rounds for, is it June 18th, I guess? Yeah. Doesn't seem like June 18th outside, but hey. This morning, it's my great pleasure to introduce Dr. Marco Gotte. He is a visitor from the Netherlands. Dr. Gotte got his medical degree from Erasmus University in Rotterdam in 1992, and then went on to do a PhD at the VU Medical Center in Amsterdam on MRI tagging and cardiac remodeling after MI. In 2005, he became a cardiologist, and from 2011 to 2017, he was a program director and director of the MR service at the Haga Teaching Hospital in the Netherlands. Since 2017, he has been at the AmsterdamUMC, leading a clinical interventional MR program there since 2018. He works on electrical activation of the heart using cardiac MRI and ECG imaging. He's been interested in the interaction between cardiac MRI and pacemakers and the impact of pacing on the heart. He's also looked at the integration of cardiac MR with electrophysiology workflow and the application of 3D imaging to characterize arrhythmogenic substrate. In 2020, Dr. Gotte performed the first MR-guided ablation in humans at AmsterdamUMC, and I hope he'll talk about that today. Thank you, Dr. Gotte. Thank you for coming, and we look forward to your talk.
Thank you for this introduction. It's really a pleasure to be here and to speak about a topic I really like, cardiac MR and Electro Pathology, basically. And I will tell you something what we are doing in Amsterdam, and then consider this as a new avenue to improve cardiac care for patients suffering from arrhythmias. My background, I'm an imaging cardiologist, so I do not much know about electrophysiology. I'm not practicing it. I'm not an interventionist. I'm just looking how to get the best images out of it. Do this in Amsterdam, and I've been indeed been a trainer for cardiology in the past. This is an overview of what MR offers us today, and this is my workspace. So it's a lot which MR offers today, but I will concentrate on the role of MR for electrophysiological purposes and applications. And the reason why I'm so delighted about MR is that it's a very powerful imaging modality. And this is, for instance, something I always discuss with my fellows and students, the clear images that out of these images, potential amount of patients result in a new or other diagnosis. So it's a very powerful modality, and it gives you detailed information about the function and the causes of diseases. It drives me. But now today I will talk about the arrhythmic substrate and MR and how to treat it. So this figure, I think most of you know this figure. This is a famous figure from indicating a substrate for arrhythmias, including for both tissue, as shown on the left panel, but also the corridors or conduction areas causing arrhythmias in circuits. This is important. This is one of the major drivers of arrhythmia. Texture causing different circuits, and these circuits may drive arrhythmias. So it is important to know how the tissue characteristics are in the setting of patients suffering from arrhythmias. The presence of scar tissue results in reduced conduction velocity, but also non-uniform conduction and also fractional activation. And that can be reflected by late potentials. So there's a clear one-to-one relationship between the presence of an occurrence of arrhythmias, type of arrhythmias. And you can visualize, map, analyze this using catheters. Can map the voltages, for instance. Electrophysiologists have decided that there are thresholds, and above these thresholds is vital tissue, and below certain thresholds, voltages. Something to just maybe in near future. You can measure the activation, the propagation, basically, of the electrical activation of the heart over time in relation to the presence of an arrhythmic substrate. And then you can decide what to do with these particular recurrence of arrhythmias, also after previous, are related to the newly developed circuits, and incomplete circuits or hidden corridors not found during the previous. Also be a reflection of progressive disease, but finally it is concluded that more than 50% recurrence of arrhythmias originates from the index substrate. Have identified the patient suffering from arrhythmias. You know that there is rate for it in terms of heart tissue. As electrophysiologists, you try to map it as possible, identify the conduction corridor, the isthmuses, ablate it, and then finally you end up with a recurrence of arrhythmias, and these are the main causes. So it is important to get a better understanding also as an electrophysiologist about the drivers of arrhythmias. And cardiac MRI is the modality that deals in types of fibrotic tissue. We have basement fibrosis, which can be this and quantify it using T1 map strategies. So we are able, with a non-invasive imaging modality, present and how it is distributed over the heart and how it might impact, or what are the consequences for the patient in that particular situation. LGE imaging, I think you are familiar with this, is a cornerstone for cardiac assessment using MR, where you can visualize the scar tissue, and bright is bright. The high signal is dead tissue. It's indicating the fibrotic tissue due to the accumulation. Visualizing this, it's a common strategy to visualize scar tissue in an MR, and you can use this also for state characterization. And on top of that, you can use, for instance, quantify the presence of diffuse properties, which could be worthwhile to know in the setting of patients suffering from it. Then the workflow could be that you scan these patients, require a couple of set of images, and then update the rate and guide basically to certain how to approach this particular patient and navigate the catheters and know. And this is important since the fact that we can characterize the arrhythmic substrate is important for the prognostic value of patients. If there is fibrotic tissue present, the risk, and has published about this multiple times. So it is important to know that there is something going on, that there are changes in the tissue characteristics, might be associated with sudden cardiac risk, death, and now also embedded in the guidelines, it is mandatory to study these patients, quantify the presence, and localize the risk stratification. With the improvement of imaging, we're now also able to characterize more details in the wide area. So in the past, we had just the fact that black tissue is healthy myocardium and the white tissue is just, now we talk about the 50 shades of white actually, and own property. Hence the situation of this patient. So we can now delineate core infarct from border zone, from tissue, from healthy tissue, and we do this based on thresholds. So electrophysiologists use thresholds to decide based on the voltages to vital or non-vital tissue. We use the signal intensity changes in signal intensity, of values as indicated over here, to decide if tissue is vital or non-vital, or we assign it to the border zone. The border zone is well known to be with the increasing imaging quality, we are now also able to visualize scar through the myocardial wall, so from the endocardium to the epicardium. This is an image of a patient with an anterior myocardial infarction, and they have created layers through the wall in 10% wall thicknesses, indicating how the scar tissue basically is present through the wall from the endocardium to the epicardium. This is important to realize and understand, since this might be one of the factors for recurrence. Then scarring in the middle and at the endocardium, if there's border zone, the epicardium area, then might occur from that particular state. Software allows us now to visualize these conduction corridors. And then again, this is all based on signal intensity. So we are playing with signal intensities and we assign characteristics to the signal intensity areas. So if we claim that there's a conduction corridor, since there's lower threshold, we assume that there's two certain. Sometimes we also think that's a one-to-one relationship. It's not. But it's important to realize we are playing with thresholds, try to identify these corridors and get a better understanding of why patients suffer from arrhythmias, but also how to approach these patients to treat them. To obtain these images, there are two strategies, 2D and 3D latent gadolinium enhancement imaging. Most sites out in the world use 2D imaging, so a stack of, for instance, short axis images with a certain slice thickness, 6, to detect and quantify the present amount and localization of scar tissue shown. And there are gaps between these slices and these slices. The acquisition requires multiple breath holds, but it is in total a relatively fast imaging strategy. It's workhorse strategy. In Amsterdam, we use the 3D approach as shown over here with navigators. These are the top of the dome of the liver. So this is more time consuming. Quality is in parallel to compare to the 2D strategy. Also related to a higher voxel size, so a higher spatial resolution. But the penalty is that your acquisition is prolonged, but not a penalty actually. With much more detailed info. All patients suffering from arrhythmias apply this imaging strategy. Reference, we scan basically all patients suffering from arrhythmias, patients that need to settle for an EP procedure. All these patients undergo the other challenge then is that most patients suffering from severe arrhythmia ventricular and MR are general conflicting components. But gradually we have learned, now we scan basically all patients, also with ICDs, patients with subcutaneous ICDs and loop recorders, all these patients. For us in Amsterdam, there's no limit, no barrier anymore. We have workflow for safety measures, learned how to anticipate the artifacts. That does not mean that there are not always artifacts. There are sometimes artifacts, but we strive to interpret it from a clinical perspective. Quality is not necessarily the same as what you would get without an ICD. We can do this for cine imaging, as shown over here, but you can do this also for this 3D LTE imaging. So that. You'll see ICD lead over there, but it does not affect the quality of the image and affect the interpretation, post-processing steps we have to be taken for analysis in this. There are multiple tricks, and we learn more and more how to play with the scanner to anticipate artifacts generated by the ICD. I think the only thing you cannot anticipate is if the ICD is less than 3-4 centimeters from the heart, you will always have some kind of artifacts. But recently there are a couple of publications where they combine black blood and bright blood LGE imaging fraction. Images are obtained at the same moment. Is also the area prone to the artifacts. But it's from the ICD perspective or the device perspective, not to scan a patient. Quality perspective, we are improving and we're already pretty good in evaluating these patients. So the role of MR is expanding. I showed you at the beginning of my presentation, bright, black, dead, and vital tissue. Now we are looking to the details in the scar tissue to come up with the conduction corridors. Where are they located? How many are there? Exit points, entry sites, which is worthwhile information, valuable information for the electron. And the devices present in these patients are no roadblocks anymore. Then you can come up with these kind of things. That's the next step. Once you have these MR images, you can use these images, create this with the electrical anatomical maps obtained during electrical physiology. Then it becomes difficult. Play with these thresholds. Blue, red, colored shell indicating scar tissue is based on thresholds and convention 40% or whatsoever. Physiologist uses the threshold he's used to come up with this electrical anatomical map. And when we compare these images, and we are not, of course, not the only one, but cannot be our institute with the electrophysiologist, they told rubbish. There's no comparison. There's no alignment between the electrical anatomical maps, bar maps you provide. So the one-to-one relationship between the electrical myocardial characteristics and the characteristics is not a one-to-one relationship. Play with the thresholds. If we modify the signal intensity thresholds on one hand, we can change, of course, the areas of scar tissue or conduction corridors, but the electrophysiologists can do the same. Last couple of months, I see some small papers coming out also. Start to reconsider their thresholds they use for the up to recently, when they did not use MR or were not aware of MR and the capabilities, there was no need to discuss the thresholds used in EP space. Now we are offering some information for the relationship between electrical characteristics and the, but we are aware of the fact that if there's scar tissue, that the risk is higher, more occurrence or arrhythmias. So it forces also the EP thresholds, and maybe we should come up with a better strategy to align this, to use types of information, data. We are working on this. So gradually there's a change. This is another example to indicate the high spatial resolution. So this is a patient lesion in the past. Areas with a high density, also in this papillary muscle, and if you do the post-processing spot over here. So this is a patient with not that much scar. They did an ablation in the past in another institute. The patient had recurrence and was referred to our institute for part of our workflow, we did this examination with these images, which was very helpful in this situation. This is from the group from Barcelona, where they also integrate another strategy of acquiring 3D LGE images, phase sensitive imaging with electrical anatomical maps. And they also now start playing with the vessel side of the imaging, but also better aligned image. Question is still on what basis you modify the thresholds. You cannot neglect the image data, optimize thresholds you use to the developing field. Problem with all these strategies is a lack of standardization of co-registration. At one point in time, you acquire a heap of images. At one point in time, you execute your right to bring this all together, but there is no standardization at this point. So we need landmarks to fuse the co-registration errors in the range of 3 to 5 millimeters, which is essential. Thresholds, I highlighted this already. This is an important novel debate, actually, from a scientific perspective, an interesting debate. And also the timing and logistics is, of course, an important issue. When to scan patients and are available and when to perform the on the other hand, if you are able to implement a workflow where you can use the R data for guiding your ablation procedures, it definitely improves the outcome. So this is in slides from Andre, 2017, in all cases where patients were ablated based or guided by MR data, the outcome long term was better. Paper from Soto in 2020 also indicated that better outcome, but also the procedural time is reduced, so it's more efficient, and also the amount of ablations, a more tailored way of ablating these patients. But then the question is, we have this time frame. We have acquired images. We need to co-register this with the EP procedure. Nature of MR is tissue characterization. It's not something which is added to the technology. It's part of the technology. So why would you not perform ablations in an MRI environment? Basically, you talk about the translation of this situation where you can visualize both the cardiac structure, tissue, and the catheters. This is one of the ablation catheters via the VCI to the right atrium. If you want to do this, you have to transform your conventional MR facility into an interventional facility. Our scanners are based Department of Radiology, somewhere down under the basement. But if you want to do interventions, you need to transform it. So this is, and there are no much examples to do so. And you will not buy first a new scanner before you start doing these procedures as well. I did this 3 times now the last years, so I think one in the world that it most frequently the transformation of a conventional scanner into a interventional scanner in a suite. You need extra cameras for monitoring. You need them in the scanner room, control room. Displays monitors to provide the information to the electrophysiologist, which allows you to couple third-party equipment, ablation equipment, scanner. You need modified sequences, and of course, every component has to be MR compatible. Just before we changed this conventional scanner, and this is an Avanto Fit, so it's an older type of scanner, 1.5. We stripped the whole room, and this was all the equipment we had to install. Then we had this control room, a little bit outdated, but we have this imaging section in the middle, which is standard procedure. We have now the EP part, and we have also the anesthesia around. In general, anesthesia is already present in an MR situation in children and IC. I'll add something else, the EP part. Clinical implementation took us 6 months, so we have to train a team. You bring together, you basically build a new team of experts. They are already experts, the MR technicians. They know what they are doing with the context, the guiding you in executing procedures. Everybody totally new. So we did a lot of training sessions, wrote many scripts to go through this. What I learned back in those years, this is 2008, quite hard class, is everybody is like that we can perform interventions in the MR facility. Everybody wants to do its best. It gives a high focus. Then you're not aware of what's going on. And there's also the safety, the risk. So we introduce also a safety officer to oversee the whole situation, not part of the procedure. The task is to monitor the safety of the patient. Tested a lot of setups, equipment, draping, imaging. This is quite hard to have an inflated balloon, so air-filled balloon. Question was how to record the dynamic data. There are no commercially available systems allowing you to collect data, blood pressure whatsoever, and store it like you do in cath environment. It's not existing. We had to come up with solutions, and then finally we had also some ablation equipment. Another important aspect, this is my colleague Cor Allard. He's an electrophysiologist in Amsterdam, and he had also to be introduced into the power of MR. He came never in the basement. It was not his environment, so he feels now the strength. It is important since he's used to ask for devices and use them. Level. This was one important aspect, also for the part of the training. The other thing was more important. When we are doing training, we use the phantom. You put this or non-beating expanded heart. And the first reaction of somebody turned the light on, he could see everything, the heart, the structures, the ridges, etc. But then he got frightened since his eye-hand coordination, bending of the catheter, didn't bump. But I was surprised. I just could see which direction you had to take, but he was not familiar with that. So that took some time to retrain, relearn your eye-hand coordination. This is an overview of the different components required to set up such a facility, ranging from safety issues, monitoring, EPG, defibrillator, the tracking, I will speak about this in a minute, additional equipment and communication. We use an MR400. It's a conventional monitoring system, are compatible to monitor blood pressure and trigger the scanner. But in this situation, the problem with this system is that it doesn't allow you to store data, so it's instant information. There's no logging of what is going on, and we solved this, otherwise I could not show you this. The other thing is the defibrillation. So this is a pig, obviously. And if you defibrillate a pig with a conventional defibrillator, it looks like this. Comes up in the scanner. So this is not for human use. But on the other hand, the good thing is you can defibrillate in the scanner. But we need to tackle some challenges. This is from Ehud Smit. He modified the conventional defibrillator, and they did some tests, not the defibrillation itself, of course, but also the impact of the presence of the defibrillator in the scanner and how it affected the image quality. And they did some scans, It turned out that there was no heating, was not a substantial artifact. The defibrillation was successful in a swine, and so you can defibrillate. The heating is not a big issue. The problem is there are no certified or approved defibrillators out there. There's currently a German company in the final stage getting approval for an MR-compatible defibrillator. Important. This defibrillator can only defibrillate, but has no pacing capabilities. The other aspect, which is essential, is 12-lead EKG recording in the MRI environment. And there are several options today. This is an example of the Myrtle system combined with the Imrecord Advantage system. It offers you a standalone 12-lead EKG recording system. You can plug it into the Advantage ablation system from Imrecord, and then you can record these signals, which is essential to electrophysiologists. If this is not possible, nobody intends to start ablating in the MR environment. However, there are a couple of factors influencing the EKG, ranging from the gradients, it's rapidly switching on and off of gradients, which gives a lot of noise on the EKG signal. Magnetic hemodynamic effect, so the fluid column in your aorta is going up and down, and that distorts the static magnetic field, and that gives also some artifact on the EKG. Have some baseline noise, and of course you can filter, but electrophysiologists are looking for tiny details to decide how to proceed, what to do, and to are effective in their ablating strategy or not. So there's also a critical balance between filtering options, and clinical information which is required to execute the procedure. This is a very intriguing field. We also have a background in body surface mapping in the past, and I've now tried to combine the electrical EKG recording in the magnet with real-time imaging. All these factors influencing the EKG. Hopefully, in the end, we will have a 3D representation electrical activation based on only electrodes positioned on the thorax of the patient. A lot of scientific work is currently going on in this field, and there are more and more small companies starting up, coming up with different solutions to offer you a robust clinically during MRI scanning. So we have solved a lot of things. We have a hemodynamic monitor. We did some problems ourselves. We have an EKG recording system that is not yet at the level you want to. There is a defibrillator coming, but today it's not present. And track devices, I will show you in sessions. We have software and we have bioptomes and other stuff available. We start doing in patient first procedure in patient where pressure recording. So we use the conventional Edwards Strong-Gans catheter. Since it's plastic, there's no connection with the scanner. We modified the MR400 to be able to record and store the pressures. And we use this as a training, basically, whole team, how to navigate, which image planes are convenient for the interventionalist. Is it feasible? And yet, we did this in patients scheduled for mitral valve plasty, so this mitral valve insufficiency, but it as a model for left atrial remodeling increased pressures. And we wanted to know the pressures in the lungs, of course, but also in the right ventricle and the right atrium. So we were able to store the data, the curves, and the next challenge was to retrieve the data in numbers. It's also not provided by this system. So we came up with a solution to what is recorded, transform into the numbers. We have the change in volume over time, the change in pressure shown over here, change in certain frame rate. And then the next step was to integrate this. Finally, we were able to construct pressure volume curves of every heart compartment. The challenge now is to accelerate, to increase the temporal resolution of the cine images, since it's relatively low frame rate, but we proved that we can derive pressure volume curves strategy. Then we moved on to the MR ablation. And there are different ways to track devices. I've shown already a couple of examples. And the first strategy is passive catheter imaging. So again, they're based on passive characteristics of the device or catheter, or in this case, a Songans catheter. And without the connection with the scanner, you can follow, in this case, the air-filled balloon over, and you have to adjust manually the image planes to guide the interventionist to navigate the catheter. Second step is more complicated and requires more equipment. There's a direct coupling between the catheter tip coils and the scanner. So there are two building coils in the tip of the catheter, and they are directly connected to the scanner, and the scanner recognizes these tips. And this gives you the bright signal coming from the tip, how you can navigate your catheter. We are now at this stage where we have a kind of mapping navigation system, a Carto maybe 0.1 or 0.2 version, but it allows us to visualize in a 3D shell acquired at that moment, vision of the catheters, again, based on the coils built into the. Also, acquire real-time images in different orientations, so multiplanar fashion is also feasible. From an imaging perspective, this is a major advancement. That's clear. You can now track, follow, see where you are with your catheter, and one of the outcomes for a procedure is also the accuracy of navigation. Way better than maneuvering your catheter in the fluoroscopy or in an electroanatomical map, which is a rigid shell where the heart is beating, contracting, moving. So there is not a specific spot where you ablate. That's not the case. And we see it now more and more. We can prove that it is not the case. But on the other hand, this shell is static. So to a certain extent, it is also. Yeah, the shell gives you an impression of the heart, but in the meantime, the heart is moving up and down. So I'm still in the phase between these two strategies. Finally, for electrophysiologists, it will become the right panel, of course. But we are working, that's another line of development, something to be considered. Requires more engineering, more software. Formable 3D model. We are working on this, a couple of sites are working on this, but we are now one of the first sites playing with this system, and it's great compared to this situation. This is the catheter with the building coils. Started with the old generator, since this was the old generator, the only generator with an optic fiber temperature sensor. And there are different ways in imaging and different ways of consequences in passive and active tracking shown over here. Real-time thing, the real-time still limited. You need an interface which allows you to connect the scanner with software for the devices. You have the static shell I mentioned. It's more easy to implement, but it is finally not the best way to proceed. Workflow. So we, at the beginning of the procedure, while the patient is in a magnet and the electrophysiologist is still preparing the caths, flushing, etc., nulling, whatsoever, we acquire a 3D data set without gadolinium. We segment it semi-automatically and upload it in the system. So within 5 minutes, a very detailed shell. Then he can maneuver, navigate the catheters in position. Finally, he can ablate. So what we have learned, even in the setting of flutter ablations, which is a relatively simple flutter ablation procedure, it accelerates now the procedure. So the eye-hand coordination is in place, how to maneuver. We understand which image plane he wants to see. So we are now faster than the conventional flutter cases. This is a side step to demonstrate that we indeed work on a real fast 3D real-time imaging framework, allowing us to get frame rate of in 3D of 25 frames per second. So the objective is to provide the same frame rate as an interventionist. Phantom tests to measure things in accuracy, etc. while we were doing this, we recognized that there is a confusion between the imaging team and the interventional team. We talk about RAO or LAO versus short axis or long axis right ventricle. It's totally confusion. So we came up with this small publication, but very helpful. This image and this image is the same part of the heart. So it closes the gap. It bridges the differences in nomenclature used in the EP space for it. Finally, we of course, the periprocedural lesion ablate, the intention is to change the characteristic of that particular tissue, and MR allows you to visualize this. This is in a pig, and we ablated the posterior wall of the right atrium. So an edema-sensitive sequence prior to the procedure. After one ablation run, 5 minutes, and there's an instant reaction affected by this increased wall thickness due to the ablation. And in 50, there's also an increase in signaling, affecting the piling up of edema. You are aware of this as an electrophysiologist. If you position your catheter and you ablate, you want to go back to that point sometimes, it's a little bit higher. You cannot wall thickness, but the increase in wall thickness also affects your efficacy of your ablation. The penetration of energy is modified by the presence of edema. Monitor it, we can measure it. The other thing is, we strive to come up with a strategy where we can evaluate the lesions created without the need for a contrast agent. Rationale behind it is if you are to tailor your therapy while you are ablating and you have bolus, again, contrast. So this is again in a big twilight sequence where you can visualize, in detail this area where we have ablated. You have to realize that we can depict this area, the high signal, within an area with a lot of edema. We are able to distinct changes irrespective of the presence of substantial amount of edema. And this is not correlated with the conventional 3D LGE, but the area with hyper-enhancement on the larger due to the edema. Same strategy, not that clear, but this is also the twilight that we could observe. I cannot rotate this. We could see the lesion line created without the need for a gadolinium. So offers the prospect of ablating without the need of contrast agent. So you can re-evaluate every step you have performed during the ablation procedure. Another example where you can see the swelling basically of the isthmus for the patient. Further, how substantial that is, and the striking thing is, this already starts after the first ablation point. It's not just one ablation point and then gradually it grows. No, it's the first ablation point and suddenly the whole tissue blows up already. Also in the area more distant from the location where you have ablated. The other thing is we scan all patients after PVI, so that is not an ablation performed in the scanner yet, since we cannot cross the septum, but we scan 4 or 72 hours after the ablation. For all patients had a scan prior to the ablation. And the protocol includes that highlight. And striking thing is there's a lot of edema, so the collateral impact of a conventional successful ablation is massive. Whole atrial wall is thickened, the colon, there's always pleural effusion. Crazy. If you see this, then you realize what you have caused as a reaction. We use also twilight, so the non-contrast gadolinium-based sequence. In the 24 hours after an PVI, it's not that successful due to what we do is we administer contrast using the twilight sequence, and then you can very distinct areas around the ostia of the pulmonary veins, and they correlate nicely with the 3 follow-up LGE in a spinal dense scar. So we are working our way into a direction that we can find a solution still to visualize lesions created in the presence of substantial edema. Another feature is this one. You can see 2 rings. Maybe you might recognize them, but these are the ablation rings around the pulmonary veins. This is a 3D LGE image acquired within 24 hours after the ablation. But it's a conventional 3D. And we visualize this using circle. It's not meant to use it in this manner, the circle module we use for this, but it gives you a good impression. And we're now looking into ways how to measure this. And also, if we see gaps in these rings, can we locate them? Can we get the coordinates out of it? And how does this relate to recurrence over time? And is it helpful to incorporate this information if there's a recurrence and a redo procedures? This is another interesting thing. So this is a patient scheduled for a CTI, and then you can clearly see this ridge you're familiar with. But we know this up front of the procedure. So is it a steep ridge? Is it a stiff ridge? Is it a floppy ridge? Are there pouches? You can see this clearly, but you can also better understand if you have your catheter positioned over here and you say, okay, I ablate for 1 minute. But the version is 2-3 centimeters. Ablating, there's no ablation point. There pouches is then the catheter, we see it bounce up and down on these pouches. All these aspects, we were aware of this. Components determine the outcome of the procedure, but now we can see it. How we can use it, we are still in the phase of learning, but it is tremendous what you can see related to the outcome. We published a review about the different components of lesions over time based on MR. So what is basically a temporal and what is a permanent lesion created during the procedure. I think finally, T2-weighted imaging will not survive in this search for a non-contrast agent-based imaging strategy, but we need to optimize the T1 or T1-weighted strategies. Also an overview of what we do. Patients scheduled prior to, after the ablation and months. And now the difference, and we work from the difference between 72-hour scar tissue and after the and you can observe the pre-existent scar tissue, also the change in shape also affects the density of the scar. Finally, we are looking for alternatives. We cannot test everything in patients. Where we have a expanded beating pig heart, and this is a normal working heart with a right to left flow. So it's not a Langendorf perfused heart. And we have adjusted electrodes on the surface of the heart. We have also a kind of bucket with remote electrodes. And the interesting thing is the whole system is MR compatible. So we are working our way to a MR compatible platform where we have a beating heart with which can be positioned in the scanner, and we will use for sequence optimization and device development. This is an overview of what's going on in general, and we are part of it. Important topic, lesion characterization under different circumstances. Integration with the electrical anatomical maps is important to us. So this for a second, but I didn't talk about this, but this is also intriguing, the 3D electrical activation without the need of infarction. Finally, we have this expanded beating heart. Part of the team. Thank you very much for your attention.
So we'll open up for questions. I'll just turn on the mics here. Oh, Vikas.
Thank you. That was a great talk, and being an EP doc, that's very interesting to me. One of the questions, you might have said this earlier, but did you need to use special EP catheters in the MR environment, or could you use just regular sort of catheter?
No, you need this specially designed catheters for two reasons. The first reason is to be able to track them. So you need catheters with the built-in coils, which allows you to track. The scanner recognizes the two coils as different coils. That's critical. And the second thing is, a conventional catheter is a huge antenna. So it absorbs a lot of energy. And the other modification in this type of catheters is that there are a lot of conductors in a row, which avoids the risk of accumulating and collecting a lot of energy. So you cannot use conventional catheters. You could consider this issue would be low field scanners or low 0.5 T scanner.
Yeah, so thanks for a great talk. Just so interesting. So you mentioned the issue of, I'm thinking about the pain points that this technique solves of doing invasive MRI, right? Or interventional MRI. And so you mentioned co-registration as one of the pain points, but can you comment on some of the pain points that this technique would solve? Like what are the things that this helps in terms of doing a procedure?
If the co-registration is accurate, you mean? Or in general?
Sorry, say that again.
If the co-registration is...
Oh, you mentioned co-registration as one point
Yeah,
of
it's one
a
point,
pain
yeah.
point, but I was
In
thinking about
particular,
co-registration amongst other
if
things.
you acquire an image data set at one point in time and execute a procedure at another point in time, so you have two separate situations actually, the pre-existing data set and your current situation with the intention to ablate a patient, you have to import the image data, but the alignment is not always easy to execute. And if you think in terms of how and what affects the outcome of a procedure, it's first the selection of the patient. If you execute an accurate therapy in the wrong patient, the outcome is rubbish. If you have a good patient, but you are not able to execute your procedure accurately, it is also rubbish. So the co-registration is mandatory to my opinion, in particular, since we try to combine image data with electrical data, and there are a lot of things going on. It's not a one-to-one relationship. And if you have this misalignment, it's a co-founding factor affecting your interpretation.
Great talk, thank you. Two questions, but they're related. So a lot of the sequences are really interesting, in particular, like the 3D LGE sequence, I think is really useful. But what's the time for that compared to just a 2D LGE typical acquisition? And then my second question was going to be, what's the time for this interventional ablation procedure in the MR magnet compared to a typical just VT ablation?
Yeah, so the first question is how 3D LGE
acquisition
time relates to 2D.
Yeah.
I think in general, it's doubles. So it takes you between 7 and 12 minutes to obtain a proper 3D data set. And it is partly dependent on the rhythm of the patient at that moment. If the patient is in atrial fib, then it prolongs the acquisition, obviously. We try to cardiovert these patients prior to the scan, if they are in atrial fibrillation, for instance, or further. But on the other hand, the information, the details in the information is tenfold higher. So there's just one data set. And I think for now, it's challenging, it's cumbersome, and it takes some time. We pioneered also, this was a D-navigator 3D LGE imaging. So we position navigators on the diaphragm, and they track basically the up and down position of the liver. And based on that, the scanner acquired data. We did also some tests with the iNavigator. It's proposed by Siemens. So it automatically tracks, for instance, the position of the right coronary artery over time. But the image quality, it's twice that fast as the conventional 3D LGE, but the image quality is less. So we did a study, we published about it, we did a comparison. We finally decided for the image quality, we stick to the conventional 3D LGE. Also for scientific perspective. We want to have these excellent images. Maybe in future, not necessary that you have this kind of detailed information to improve your outcome, but we stick to this for now. Your other question was,
What's the time for one of these VT ablation procedures and the MR magnet?
yeah, we currently not yet perform VT ablations. We are about to start doing so, and that is a next level of performing interventions in MR, since then you have to cross the septum first. So that would be the first in-human MRI-guided transeptal puncture. And we have these sheaths already in place. They have the same technology, so building coils in the tip of these sheaths and R-compatible needle. So we have first to cross this, but we are in the stage now that we are practicing. So we use phantoms. Okay, what are the best image planes to do this? We are currently doing this. The second thing is we could do this without an defibrillator on board, but everybody's watching us. This is the first time you perform such a procedure. So if something happens, it will have a massive backfire if we are not well prepared. And there's always the delay to take out the patient out of the magnet, bring them in the prep room and defibrillate it. If you compare it to a conventional setup, you just push the button and you continue what you're doing. So that's the only reason we are waiting. We have medical ethical approval. We have everything in place with the equipment tested, and we are practicing now in phantoms to already get familiar with this next type of intervention.
I enjoyed your talk, and it's a tremendous amount of work to try to combine MRI and EP ablation procedures at the same time,
Yeah.
not to mention the amount of money that must cost. So you must have some outcome data to show that the results are better than when you do it now.
We cannot state based on data that it is better based on this strategy, but what I always tell is the current strategy is also not that good. We have to re-ablate a substantial amount of patients. And the reason for this is one, the selection, you can work on that, but also the execution of the procedure. Of your findings during an conventional ablation procedure. The electrophysiologist relies on the electrical signals at that moment. The electrical signals are determined by different changes in tissue characteristics, ranging from temporal and permanent lesions. Solve this, and then you will get a better outcome. That's my and the VT, ventricular tachycardia approach, is something new. We are almost there, and that's clear. You have more insight up front. You know where conduction corridors are. You know the coordinates of these conduction corridors. Start looking for these corridors before you start creating an anatomical map. The whole process, in my opinion, will change finally, and you get providing all this information based on the image data. There is a simulator from the company Edis, which allows you already to practice in patient data the whole procedure in real. And it's more about the confirmation with the catheters in place and execute it. So finally, it will definitely change the way how we ablate patients. Not for all patients.
Online, we have two very practical questions from the chat.
Can detect CMR fistula post-ablation. We haven't never seen them. I don't know. I think that would be very hard since due to the edema, the tissue is swollen, so it's very difficult to think areas or disconnections or a hole in an esophagus. I'm not familiar. We have never encountered such a situation. How many procedures can you do per day? We do now 3 to 4 procedures per day. So what our scanner, our current scanner is part of the Department of Radiology. The Department of Cardiology hires basically the scanner for 1 day, and we are free to play with it as we like. We do also a lot of research, so it's not only about the ablation procedure itself and execute the procedure, but we scan also a lot. So that's why we stick to 3, but we could 4 or 5 if we want to.
Thank you. We are past the top of the hour, so I would like to thank Joel for his talk, and I hope you enjoy the next couple of days. We've got a busy schedule for you. Thank you.
And then I'll.